All right, so we'll go ahead and start lecture 28. This lecture, we're going to concentrate on Rhogam. Now, I have a disclaimer. Rhogam is actually the name of a specific manufacturer. So oftentimes people will say Rhogam, but that's a specific manufacturer. There are other manufacturers as well. So the more proper term is RHIG or anti-IgG, all right? So that's how, just some terminology there, but Rhogam is anti-D, all right? All right, so actually what is Rhogam? Rhogam is a concentrate of IgG anti-D, and it is prepared from hyperimmunized human donors, all right? And so what this is, it's kind of like a prophylactic treatment. And it is to prevent your building of anti-D. So if you're Rh negative, and most common reason, we're going to talk about some other reasons that it's used, but the most common reason is in pregnant females. If mom is Rh negative and it has the potential to have an Rh positive baby, mom could be exposed to baby's D positive cells, and therefore she could be sensitized and build anti-D, right? So Rhogam is given to all Rh negative females at 28 weeks gestation, regardless of what the baby's type is. And so there's the potential manufacturers now. You can have intramuscular injections. You can even have it intravenous given as well. Most for pregnant females, they're given intramuscularly. You guys might probably know a Rh negative female that has received Rhogam.
Did they only ever used to give one dose of that, like some years back, and now they do it like at 28 weeks after delivery?
Yeah, Rhogam was first developed in 1968, and initially I think they only gave it 28 weeks gestation.
Okay.
I might have it backwards on that. Maybe they started giving it after delivery, and then they came back and said at 28 weeks she needs it regardless of what the baby's type is. Okay. That might be on a future slide, because I kind of have the history outlined. We'll come back to that. But I want you guys to make sure you understand the purpose of Rhogam. It is to prevent Rh negative moms from building anti-D, okay? And I want you guys to understand too, the building of anti-D is not a problem for the first pregnancy, all right? In the first pregnancy, she's being exposed, and so she will be sensitized, could potentially build the anti-D. If Rhogam is not given, so for those females that maybe do not seek prenatal care, for future pregnancies, she will have an active titer of anti-D in her circulation. That is a concern for her future pregnancies, all right? So where ABO, there's a difference between ABO and anti-D. ABO can occur in the first pregnancy. It can occur because her ABO antibodies are already there, right? However, remember, to build IgG antibodies, you have to have been exposed, all right? And so that exposure is through pregnancy or a transfusion, all right? So for anti-D, it's not a concern. In her first pregnancy, she's going to be exposed. If Rhogam is not given, then she will build anti-D, all right? So how does that work? How does Rhogam prevent mom from building anti-D? There's several different case scenarios. Some people believe that the antibody attaches to baby cells. Those cells are taken out by the spleen. Therefore, that lowers the exposure of mom to the D antigen. So therefore, she doesn't build it. There's another theory saying that the Rhogam attaches to cell receptor sites on the macrophages and prevents B cells from being activated, therefore preventing mom from building anti-D. So depending on if you research that, you'll find some literature on both mechanisms. So it could be due to that Rhogam attaches to baby cells, the spleen takes out the baby cells, or it could be that the Rhogam attaches to the receptor sites, preventing the formation of anti-D. So the administration of Rhogam helps protect moms from building anti-D, about 99%. And it's given to those 28 weeks of gestation to all Rh negative moms, okay? This is not a concern if mom is Rh positive, right? Rh positive individuals do not get Rhogam. You will have some clinicians, I promise you, that call you and ask you about Rhogam, and you have to tell them your patient is Rh positive, there's no need for Rhogam, all right? And then if mom is Rh negative and delivers an Rh positive baby, then she will have a postpartum dose of Rhogam within 72 hours from delivery, all right? If the baby is Rh positive. And just some statistics, Rhogam has reduced the hemolytic disease of the newborn from 13% to 0.2%. So Rhogam significantly has reduced hemolytic disease of the newborn. And I want you guys to understand, anti-D is not built in every situation, all right? It just depends on the amount of bleed that occurs, the number of exposures to the D positive cells, and then mom's immune system. How likely is she to build that antibody, okay? A lot of these situations, you think an O mom has an A baby, oh, hemolytic disease in the newborn is going to occur. It doesn't. Sometimes it doesn't occur. These are just scenarios that can happen, all right? So just to give you an idea of the significance of Rhogam, the effect it's had, prior to the development of Rhogam in 1968, patients, babies were dying from this, right? This is how severe anti-D is. Anti-D is going to coat baby's D positive cells. Those cells are going to be destroyed by the spleen. The baby's going to be anemic. Baby's going to have increased bilirubin, right? So before Rhogam was developed, there was no way to prevent the building of that anti-D. So for mom's future pregnancies, it caused a huge concern, even resulting in fetal death. One of the other names for hemolytic disease of the newborn, if you guys remember, was erythroblastosis fetalis. And that just, another word is hydrops fetalis, and that just means excess swelling in the baby. So the baby's anemia is going to be so severe that extramedullary hematopoiesis is occurring in the spleen and the liver. The baby's going to have edemia. Oftentimes this will occur with a swollen abdomen. And then if the cell hemolysis is occurring and increased bilirubin is so high, then kernicterus is ultimately what will lead to the fetal demise. So here's our timeline of Rhogam, and Sarah, this might answer your question. In 1940, we had the recognition of anti-D. In 1950, they started doing exchange transfusions to try to help address the severity of the hemolytic disease of the newborn. Between 1952 and 1968, they started doing early deliveries, amniocentesis to measure the amount of bilirubin present, and then intraperitoneal and intrauterine transfusions. So they started doing transfusions while the baby was still in utero. And then in 1968, it was postnatal Rhogam that was initiated first. So that would be after delivery. And then in 1984, they came back and said, everybody that is Rh negative will get a dose of Rhogam at 28 weeks, one single dose at 28 weeks. All right, and we're going to talk about dosage in future slides. All right, so let's talk about the mechanism of hemolytic disease of the newborn. What exactly is caused there? If you think about in the cord blood, there's a 2-cell thick membrane because mom's blood will go to baby, and then baby's blood is brought back to mom's circulation for the bilirubin to be cleared by her liver. Anytime there is injuries to that cord blood, whether it be during delivery, so anytime during delivery there can be a higher fetal maternal blood exchange, or anytime there's trauma, maybe mom is 32 weeks gestation and she has a car wreck or falls down the stairs, or anything where there's trauma directly to the abdomen could increase fetal maternal circulation, could increase mom's exposure to baby cells. Okay, that's the problem with hemolytic disease of the newborn. Mom's being exposed, building the antibody. And then as mom's titer goes up, antibody is able to cross that placenta and coats baby's cells, right? You guys have to understand that's what's happening here is mom is antigen negative, baby is antigen positive, right? So baby being antigen positive, mom could potentially build the antibody and which will coat baby cells, all right? And we talked about what happens in severe cases of anemia. Tissues do not get the adequate oxygen they need, so resulting in tissue hypoxia, increased cardiac output, fluid and salt retention, extramedullary hematopoiesis, resulting in the spleen and liver becoming enlarged. That's why you often have swelling, portal hypertension, and then hypoalbuminemia, and then ultimately edema, that swelling. And so you guys probably know if the antibody coats baby cells, then you'll have some cell hemolysis occurring. You'll have released hemoglobin. If the baby is in utero, it's not a concern because mom's liver is able to conjugate that bilirubin and clear it. However, after birth, this is the concern because mom's liver is no longer available and the baby's liver is very underdeveloped, all right? So it is incapable, especially if the bilirubin is present in a high amount, it is incapable of conjugating that bilirubin and able for it to be excreted appropriately. And then if it passes the blood-brain barrier, kernicterus is what is the main concern. And you guys will see this. You probably know somebody that has a baby that has the yellowish coloration of the skin. That's jaundice. Their skin takes on a yellowish coloration. You might even see it in the whites of their eyes. That's when usually they're put under the UV light for phototherapy. And we talked about how the problem after birth is mom's liver is not available to conjugate the bilirubin. And you guys have seen this chart from a previous lecture. We talked about this. This just depicts how the mom's liver can break down the indirect bilirubin to direct bilirubin. Doesn't cause, the baby will have anemia, but the bilirubin does not cause any issues. After delivery is when the issue occurs. The baby will have increased indirect bilirubin, right? And that's what will pass to the blood-brain barrier. If this case of hemolytic disease in the newborn is severe, they will do an intrauterine transfusion. We've talked about that. And then the uses of Rhogam, all right? So we're gonna do a antenatal dose. All Rh negative moms will receive a antenatal dose at 28 weeks. And then again, if mom delivers a Rh positive baby, she will receive a postnatal. So antenatal is during pregnancy. Postnatal is after pregnancy. All right, so the antenatal is during pregnancy, again, given to all Rh negative moms at 28 weeks. And again, it reduces the possibility of mom building anti-D, which protects her future pregnancies. There are some side effects to that 28-week dose that you guys need to be aware of. What's going to happen is that is essentially a passive antibody, all right? So, and it's going to look just like anti-D. So what's going to happen is mom's IAT is actually going to be positive, all right? And it's going to look like, when we do our panel identification, it's going to look like anti-D. It can cross the placenta. It can coat baby cells and cause the baby to have a very weak DAT. Usually, if mom is given Rhogam at 28 weeks and then she delivers at 40 weeks, usually when we receive the cord blood from a full-term baby, those Rhogam has been cleared, all right? So you probably will only see that if she has an early delivery. I mentioned that Rhogam will cause mom's IAT to be positive. If she's given Rhogam at 28 weeks, her positive IAT is very weak, all right? So usually like 1+. There's a difference. And when you have a mom's positive IAT due to Rhogam administration versus true anti-D, one way that we can do that is by titering the anti-D. If it's Rhogam, then it's going to be a very low titer. If it's true anti-D, it'll be probably greater than 1:64, all right? And I have an example. We're going to look at some examples like that. This is why history on moms is so important. When we have a positive IAT and it looks like anti-D, we want to know the exact date that she received Rhogam. All right, we have to prove that the D in her circulation is not a true anti-D. We have to prove that she was administered Rhogam. All right. And like I mentioned, there will be bleeds during delivery. So it has been found that if mom is Rh negative and delivers an Rh positive baby, she does need a dose of postnatal. Now, 1 dose of Rhogam will clear a 30 ml total bleed. All right, so 1 dose of Rhogam will clear 15 mils of Rh positive cells. In the event that mom experiences a trauma where there's excess bleed, large amount of fetal cells in mom's circulation, or maybe a traumatic delivery, more bleeding occurred, she will need excess vials of Rhogam. All right, so if she had a higher bleed, then she does need more than 1 vial of Rhogam. All right.
So you said
we're gonna talk about how we detect that. What'd you say, Sarah?
1 dose clears how many mLs?
One dose of Rhogam is like 300 micrograms of Rhogam. It will clear a total 30 ml blood loss. All right, so a 30 ml blood loss usually have about 15 mils of red cells in it.
Okay, thank you.
So that's what 1 vial of Rhogam will clear, okay? The problem occurs if there's a significant bleed. Something that can happen if there is a significant bleed greater than 30 mils, mom is supposed to be Rh negative, right? And so when we do our testing post-delivery, we do our week D testing on mom. She has historically tested as Rh negative. Because of the significant bleed, and now there's some Rh positive cells in mom's circulation, it is possible we can see mom to be weak D positive. All right. And so that can occur if the significant bleed has occurred. And again, postnatal, the baby must be Rh positive. So you have an Rh negative mom who delivered an Rh positive baby, she will get a dose of postnatal Rhogam. If for some reason mom delivers the baby, maybe the baby passed away, or the baby's type is unknown, it is better to give Rhogam than not to give it. All right, it will have no adverse effects on mom. So if ever in doubt, if your clinicians want to give it to an Rh negative individual, they can. All right, it's better to give it than not give it. Now, if mom has already developed anti-D and she's Rh negative, she has true anti-D, she does not need Rhogam. Okay, she has already been sensitized. She has already built the antibody. There's no point to give her Rhogam, all right? All right, so if you're doing postnatal testing on mom and you detect anti-D, we always want to look at the history again to determine if that's due to Rhogam or is it due to true anti-D. You want to evaluate the antibody level, all right? That's looking at your titer. So usually if you have a real anti-D, that titer is going to be high. Usually if Rhogam has been given, the titer is going to be low, 1 to 2, 1 to 4, 1 to 8, all right? That's what the titer we'll see with Rhogam. And it's very important to make sure that there are no other antibodies present as well, all right? So we focus primarily on anti-D, but you want to make sure there are no other clinically significant antibodies as well. So it's possible your mom might have multiple antibodies. All right, so we talked about giving Rhogam to Rh negative moms. What if mom is weak D positive? All right, so theoretically, she is classified as Rh positive. Some clinicians say that she does need Rhogam. Most literature will say that she's Rh positive, although it's a weakened D expression, that she does not need Rhogam. So you could argue with clinicians. Some people want to give it, some people don't. So that topic is controversial. Theoretically, she's Rh positive. She doesn't need Rhogam. But some clinicians believe that she should get Rhogam. The problem with that is if you don't have an established history on her, and maybe a mom that shows up to the hospital just to deliver and she hasn't had any prenatal care, and her weak D is positive. Is she truly weak D positive, or has she had some type of bleed where baby Rh positive cells are now in her circulation? That would be a problem. In that situation, probably best just to go ahead and administer Rhogam just to be safe. All right, so I mentioned that if mom has a large fetal maternal bleed, there's the need for an increased dose. The way BloodBank will determine what dose mom needs to get, and this would be postnatal, okay? Because at 28 weeks, or in the event of a trauma, at 28 weeks, mom is just going to get a standard 1 vial of dose, okay? This would be after delivery or in the event of a trauma. BloodBank has what we call a fetal screen, and it is the rosette test. We will do this in BloodBank. If it is a negative test, meaning that there are little to no Rh positive cells found in mom's circulation, that's considered a negative test. She gets the standard 1 vial of Rhogam. Okay. However, if the fetal screen is considered positive, meaning that there is a large amount of Rh positive cells in her circulation, then she needs extra doses of Rhogam to clear that bleed. Okay, and I'm going to tell you, we're going to go through the rosette test, what that involves. If your fetal screen is positive, all right, the fetal screen is qualitative, meaning that yes, there are cells there greater than a 30 mil bleed has occurred. Then BloodBank will work with the hematology lab. This is the same test that we talked about in hematology. It's the Kleihauer-Betke. So remember the Kleihauer-Betke, you treat the cells, it's an acid treatment. Hemoglobin F, which is your fetal cells, are resistant to the acid treatment. So your fetal cells remain bright pink. Your adult cells will be ghost-like, right? So in Kleihauer-Betke, they will quantitate the number of fetal cells. And that will let us know the amount of bleed that occurred. And there's a calculation for that. All right, so it's about 1 in 300 deliveries results in a bleed greater than 15 mils of red cells. So 1 vial of Rhogam usually is sufficient. And we can tell this from the rosette test, all right? So this is your fetal screen. It is the rosette test. It is performed on mom's red cells, okay? So you take mom's red cells, you're gonna wash them, you're gonna take your cell suspension, mix it with anti-D, you're gonna incubate it at 37 degrees. So think about what's happening there, right? In your test tube, you have mom's red cells. Mom is theoretically supposed to be Rh negative. In the event that there has been a large fetal bleed, you will have baby's Rh positive cells, okay? And then we add it with anti-D. If there was a large amount of Rh positive fetal cells in mom's sample, then that anti-D that we have added is going to bind to the baby Rh positive cells. Okay, so that's what's happening now. Incubate, anti-D binds to your red cells. Then we're going to wash. Then we're going to add what comes in a kit. This is part of your fetal screen kit, Rh positive indicator cells. All right. I wish I could draw this out for you guys. What's going on inside this tube, right? So you have baby's Rh positive cells, which the added anti-D has bound to, okay? So now we've washed away any unbound anti-D. Now we're going to add Rh positive indicator cells. These Rh positive have the D antigen on their sites. So think about it. You have anti-D already coating baby cells. Then you add indicator cells. The anti-D is also going to bind to the indicator cells. This will give you a formation of what we call rosettes, all right? So you have your indicator cells, the antibody-coated baby cells is going to kind of form around those rosettes. And so you have what looks like rosettes, and this is kind of what's happening here, all right? So here's your fetal cells, right? The D positive cells. Here's your anti-D, and then your D indicator cells are added. And this is what forms the rosettes. And this is why it's called the rosette test. All right, so once you've added your rosettes, we can put that tube underneath a microscope. We're actually going to quantitate the number of rosettes that are seen. We're going to count them. And usually, make sure you check your package insert because I've actually seen the number of rosettes might vary. It might be 5 or it might be 7. I've seen it both. So make sure you always check your package insert. If you see greater than 7 rosettes per 5 fields, that does indicate that a maternal bleed greater than 15 mils has occurred. Hold on just one second. Okay, sorry. All right, so just to repeat that, you're going to quantitate the number of rosettes present. If you have greater than 7 rosettes seen in 5 fields, that does indicate a positive fetal screen, right? That indicates a bleed greater than 15 mils of red cells has occurred, and mom has a great amount of fetal cells in her circulation. All right. This means that the 1 standard dose of Rhogam is not enough. She needs an extra dose of Rhogam. How much of a dose does she need? That's where the Kleihauer-Betke test comes in. All right. So I want you guys to understand the rosettes are baby's Rh positive cells coated with anti-D. And remember that the structure of the IgG molecule has 2 binding sites. So one binding site is on your baby red cells. The other binding site is binding to your indicator cells, right? That's what forms the rosettes, okay? Just watch a movie right now, okay? All right, so the Kleihauer-Betke, again, this is the same procedure done that we talked about in hematology. It is a quantitative, okay? So the fetal screen tells us that yes, a bleed did occur. Yes, an additional dosage of Rhogam is needed. The Kleihauer-Betke is going to tell us how much Rhogam is needed, all right? It's a quantitative test. And again, the acid is going to elute out your adult hemoglobin A, and then the fetal cells that contain hemoglobin F will remain. All right, so it looks, you guys remember from hematology, it looks like this. These ghost cells are your adult cells. These bright pink one are the cells that contain hemoglobin F, your fetal cells, all right? So remember, in an adult, it's normal to have about a 1% fetal cells. So in mom, where she has increased amount of hemoglobin F, we can make the assumption that those are fetal cells, right? And we can quantitate that. We can count the number of fetal cells seen per 500 total cells. All right, and so here's our calculation. You have the number of fetal cells seen per 500 cells. That gives you the percent of fetal cells, all right? Then there's a way that you can think about this. Remember, in an average 150-pound person, the amount of blood in your circulation is about 5,000 mils. Okay, so that's where this 5,000 comes from. Take the percent of fetal cells times the total amount of blood in your circulation, and that gets you the exact mils of fetal blood in mom's circulation. Now, if you multiply by 5,000, you need to convert this percentage to a decimal point. All right. If you want to just, let's say you have 2% fetal cells, if you just want to leave it at 2, you can just take 2 times 50, right? Does that make sense to everybody? So if you use the 5,000, but I wanted you guys to understand where that number came from, all right? So if you convert your percentage to a decimal, multiply it by 5,000, because there are 5,000 mils in the average person's circulation at one time, okay? All right, that will give us the amount of fetal blood in mom's circulation. 1 vial of Rhogam clears a 30 mil whole blood bleed or 15 mils of red cells. So we can take the amount of fetal blood in milliliters divided by 30 mils, that's how much Rhogam will clear. That will give us the number of vials needed, okay? Here's the catch though. Whatever number you get here, you want to round up and add 1, okay? We always add an additional dose just to make sure that all of the fetal cells are cleared, okay? So let's look at an example. I know that sounds confusing, but when you're given an example, it'll make more sense. All right, so let's say we are doing a Kleihauer-Betke on a pregnant or recently delivered female that had a positive fetal screen, meaning that we saw greater than 7 rosettes on the rosette test. We counted 10 fetal cells per 500 total cells counted. That's 2%, all right? Convert that 2% to a decimal times 5,000, and we have a total of 100 mils of fetal blood in mom's circulation, all right? Remember, 1 vial of Rhogam will clear a 30 mil bleed. So divide 30 mils, or 100 mils by 30, and that equals 3.3. All right, so a good rule of thumb, when I said round up, a good rule of thumb is if it's greater than 0.5, round up. If it's less than 0.5, you know, keep it the lower number. So this is 3.3, so 3 vials plus the additional one to make sure we have room for error, all right, to make sure all those fetal cells are cleared. So this mom needs 4 vials of Rhogam. Does that make sense to everybody? Do not forget, students do this all the time. Do not forget to add that additional vial of Rhogam, okay? Don't forget that. And you guys will do this if you work at a hospital there where moms and babies, you guys will do this calculation a lot. Oftentimes, blood bank controls the administration of Rhogam. So we will have it in our inventory. We handle how much the patients get, and we handle which patients get it. All right, so blood bank does control administration of Rhogam. If you work at a hospital, in my experience, blood bank has always controlled that. If you work at a hospital where pharmacy might control the inventory of Rhogam, then they might calculate the dosage. But in my experience, blood bank has always handled Rhogam dosage and inventory. And we've actually talked about this before. There's some other uses of Rhogam. If you have a Rh negative patient that has been given Rh positive components, maybe in like an emergency situation, you can give them Rhogam to try to help prevent them from building anti-D. So it's not only limited for moms and babies situation. You might also see there's what they call IVIG, and it's given for like immunocompromised patients to help boost their immune system. Multiple myeloma patients I know are receiving those. Let's see, those patients with ITP or TTP might also be given IVIG, and it is essentially the same thing as Rhogam to help build the immune system. Keep that in mind though, if those patients have received IVIG, it will look just like anti-D, all right? All right, so let's go through some cases of hemolytic disease of the newborn just to review. ABO is the most common cause of hemolytic disease of the newborn. That would be where your mom is O and the baby is either A or B. Hold on just one second. Sorry. All right, and then followed by little c and anti-D is the most severe, followed by little c and KEL. All right, the amount of hemolytic disease of newborn caused by anti-D has decreased dramatically, of course, since the development of Rhogam. However, in blood bank, you will still see this because there are females who do not seek prenatal care. All right, so you will see the development of anti-D. We mentioned little c and KEL. They can also cause hemolytic disease in the newborn. And also platelet antibodies can cause problems too. So there are antigen sites on your platelets. It is known that after pregnancy, females can build antibodies to those platelets as well. We actually, that's kind of a rare instance. In my experience of blood bank, I only had that happen one time. We had a patient that had a known platelet antibody. And so what's going to happen is you're going to see your platelet count decrease after delivery.
That actually happened to one of our current classmates that I worked with. She's in our class now, Rachel Garrett. Yeah, she always jokes about how her brother almost killed her mom.
Yep.
Because she was born first and her mom developed, I don't know if is it HELP or is that part of it with the low platelet? But yeah, her platelet count just like went through the floor.
Wow. And it was due to a platelet antibody?
I'm not sure. It was weird, but I just know that like her mom had a heck of a time after delivering them.
Wow. So it can happen.
Yeah.
In those instances, if the platelet, if mom has a platelet antibody, then she would have to have either cross-matched platelets or probably HLA matched platelets. All right, so let's go through some cases. Case number 1, we have an O negative mom, weak D negative, her IAT is negative. And then if you look at baby, baby is A positive, DAT is weakly positive. All right, so given that mom is weak D negative, but her IAT is negative, we don't suspect anti-D in this case because mom's IAT is negative. Mom is O, so that does mean we have the potential for hemolytic disease of the newborn due to ABO. And then when we look at baby results, we do see that baby is A. So we can assume that this is, and because the DAT is positive on the baby, we know there is hemolytic disease of the newborn. Okay, so we can assume that the weak positive DAT is due to hemolytic disease of the newborn caused by the ABO incompatibility. All right, so it's mom's anti-A, B coding the A cells. Now we don't have eluate results, but we can theorize that it is mom's anti-A, B coding the cells. All right.
So not just anti-A then.
It could be anti-A, it could be anti-A, B. Because mom is type O, she probably has more anti-A, B that is IgG than she does that is anti-A IgG that is able to cross the placenta. So most oftentimes what you'll see if you were to do the eluate, then the baby's eluate would react with both A cells and B cells. Okay, so here's a question for you guys. Mom is O negative, baby is A positive. Does this mom need Rhogam? Because she is O negative and delivered an A positive baby, yes, she does need a standard dose of Rhogam. All right, case number 2, mom is O negative, weak D negative. She has a positive IAT, and holy cow, look at her anti-D titer, 256 is her titer. All right, let's look at baby. Baby is A positive with a very strong DAT 4+. So this baby does have hemolytic disease of the newborn, most likely due to anti-D here, this high titer of 256. Does mom need Rhogam? Remember I said that if mom has already built anti-D, she does not get Rhogam. She has already been sensitized. She already has true anti-D. She does not need Rhogam at this point, right? It's too late for Rhogam, okay? And then case number 3, mom is O negative. She has a weak D mixed field agglutination. Her IAT is negative, but the fetal screen is positive. Wonder what's happening there. Baby is A positive with a negative DAT. Does the baby have hemolytic disease of the newborn? Is there anything wrong with the baby? Baby is fine in this situation, but let's look at mom. Weak D, mixed field agglutination, all right, with a positive fetal screen. What do we think has happened? There has been a fetal maternal bleed, a very significant bleed, so much so that now baby's Rh positive cells are in mom's circulation, right? So that's causing her weak D to be positive and also her fetal screen to be positive, meaning that greater than 7 rosettes were seen on the fetal screen, okay? So while there's no hemolytic disease of the newborn here, baby is fine, what next test needs to be performed on mom? Kleihauer-Betke. All right, because the fetal screen is positive, she needs an additional dosage of Rhogam, okay? Case number 4, we have a O negative mom who is weak D negative. Her IAT is positive with an anti-D that is 1 to 256, all right, so a very significant anti-D titer. Baby is A negative with a weak D invalid and a 2+ DAT. So what do you guys think's going on with that baby? Remember we talked about the block D phenomenon? And look at mom's titer. Notice how high it is. 256. Mom's active anti-D is coating baby Rh positive cells. Remember, it's binding to all of the baby's D positive sites. That's why our baby is initially typing as Rh negative and our weak D control is positive. Okay, so this is an example of a block D phenomenon. So I would not be surprised if after you do your glycine treatment, the DAT becomes negative, and then we repeat our Rh testing, baby is actually Rh positive. Does mom need Rhogam? No, mom already has an active high titer of anti-D. She does not need Rhogam. All right, once mom has already built the anti-D, Rhogam will do her no good. All right. All right, so here's another case. This is mom at 28 weeks of gestation. She has O negative, weak D negative, IAT positive. The titer is 1 to 8. All right, keep in mind that's at 28 weeks. And then mom at 32 weeks gestation, so 4 weeks later, she's O negative, weak D negative, IAT positive. Her anti-D is 1 to 2. All right. So with this IAT positive and her titer is actually going down, do we think this is true anti-D? No. Given that her titer is actively going down and it's already low, this is actually due to Rhogam. Rhogam is causing her positive IAT and her low titer anti-D. So mom has been given Rhogam, and we are still detecting that in our testing. So does mom need Rhogam post-delivery? Well, she probably will, depending on the type of the baby, right? So if she delivers an Rh positive baby, then she will need Rhogam after delivery, all right? Now, there's a lot of debate on that. You will have some clinicians that want to give the postnatal Rhogam to all Rh negative moms, regardless of what type the baby is. Literature says that that postnatal Rhogam is only indicated if the baby is Rh positive. So don't be surprised if you guys end up working in blood bank. You might have some arguments even between the clinicians and pathology on whether or not to give a Rh negative female that delivered an Rh negative baby that postnatal Rhogam. All right, and remember, if in doubt, receiving that Rhogam for an Rh negative mom who hasn't already built anti-D won't cause any harm to her. It's just an additional cost, more testing for blood bank. So it's really not warranted if she delivers an Rh negative baby.
I had a question about, so when they get their Rhogam, is that something that they do then? Do they do the titers periodically?
No, probably in this situation, I don't know, maybe mom had an occurrence, maybe she had a little trauma or something,
Okay.
and they just repeated the testing. It is not standard routine to do at 28 weeks and then repeat it at 32 weeks. Okay. Unless mom had true anti-D, and then they would want to monitor the titer of that true anti-D. That would be the only situation. But typically at mom at 28 weeks, she won't have, if there's no issues, she won't have any blood bank testing until time for delivery. So this must have had case number 5 where we have our test at 28 weeks and 32 weeks. Something must have happened to mom. Maybe she was involved in a car wreck and they're just making sure, or maybe she hadn't, well, that doesn't make sense either. Yeah, so it must have been an extenuating circumstance to repeat testing a month later. right, so just to review the hemolytic disease of the newborn, let's compare hemolytic disease in the newborn due to ABO versus incompatible RH, okay? Remember, ABO, we see it quite frequently when our moms are O. The symptoms of hemolytic disease of the newborn are very mild, usually no further action is needed. Maybe the baby needs to sit under the natural sunlight, right? Remember, ABO can occur in any pregnancy. It can occur in the first pregnancy, all right, versus your RH or any other IgG antibody. It must occur in the second pregnancy, all right? Unless, there's a disclaimer there, unless mom has had a previous red cell transfusion in the event she has already been previously exposed. Does that make sense? So maybe she had a red cell transfusion several years ago, she was sensitized and has a active antibody already, okay? But if we're only looking at pregnancy building, that IgG antibody can only be built on exposure. So she must have been exposed to it from a previous pregnancy, right? That's the huge difference between ABO and RH or other IgG antibodies. And that's why history is so important in blood bank, especially with moms and babies. And we mentioned with ABO, your mom must be O, okay? And the baby must be another ABO such as A or B, all right? If mom has a O baby, there's no ABO hemolytic disease of the newborn, all right? Because that's compatible, all right? The problem occurs if mom is O and she has that anti-A, B, all right? That can attack baby cells. Remember, ABO, mom can be any type of RH, positive or negative. And the DAT, your reaction strength of the DAT is another indicator if you're dealing with ABO or RH. Remember, with ABO, that DAT typically is weaker, all right? With your anti-D and other IgG antibodies, that DAT is going to be very strong, 3+ or 4+. And usually, remember to always look at mom's IAT. If it's ABO, hemolytic disease of the newborn, that IAT is going to be negative. If you're dealing with an IgG antibody, that IAT is going to be positive. And then we can run a panel to determine exactly which antibody is reacting. And remember what type of eluate we want to perform. If you suspect ABO, we want to do a Louis freeze. If you suspect anti-D or another IgG antibody, we want to do that acid elution. And then once we do that elution with ABO, we will have a reaction with our A and or B cells. And then with another IgG antibody, we will typically have that antibody reacting with the specific cells where the antigen is present. The next few slides just kind of review special transfusion requirements for intrauterine transfusions, exchange transfusions, and neonatal transfusions. So a lot of, depending on how your facility is set up for this, you might have quad packs where you have the CPDA anticoagulant red cells, and it has the little miniature quad packs already attached to it, allowing for the closed circuit system to maintain the aseptic technique. And that's how, because usually babies get a very small volume, anywhere from 5 mils to 25 mils. And so typically we can pull off from the mother unit into a small quad pack. So that's what the quad pack refers to. And then you might also have your parent unit, but then you will pull off the designated amount into a syringe. I've done that as well too. So you might pull off and give that to the nursing staff in a syringe for transfusion. And remember, we always want to try to use the CPDA anticoagulant. It is less toxic for the babies, all right? So we always want to protect our neonatal kidneys. If you only have Adsol available, like I mentioned earlier, you could wash the red cells. You could wash the Adsol away. All right, fresh blood, 5 to 7 days old. And again, that's just You guys remember, as the blood is stored, the 2,3-DPG is going to decrease, potassium will increase, all right? So we try to give these babies fresh blood just because they are immunocompromised, all right? And so their organs are still developing. We want to make sure that their body can process these red cells appropriately. And then typically you will give type O negative red cells. And then here's your requirements. Remember, I mentioned this is a very good Board of Certification exam question. Leukodepleted and or CMV negative, sickle negative, wash to remove potassium if it's not fresh, all right? And then resuspended to a hematocrit of 75 to 90%. So if you were doing an intrauterine transfusion, that is when you mix red cells with plasma. And then once you mix it, we will measure that hematocrit. We'll do a spun hematocrit to make sure that hematocrit is 75 to 90%. Irradiated. If mom has an antibody, we want to do cross-match compatible with mom's plasma. And then if mom has that antibody, make sure to give antigen negative. If mom has a negative IAT, there's no antibody in circulation, but for some reason, maybe iatrogenic, maybe the baby has had a lot of blood drawn for another condition, and now the baby is anemic and they want to give that transfusion. For the first 4 months of age, if mom's IAT is negative, and there are no suspicions of hemolytic disease of the newborn, a cross-match is not required. We would just give O negative with all of these attributes, fresh, irradiated, leukodepleted, then that's fine for transfusion if there's no problems. If mom's IAT is positive or there's hemolytic disease of the newborn, then it needs to be cross-matched. All right, so in the past 2 lectures, we've talked about hemolytic disease of the newborn due to ABO versus due to a anti-D or another antibody. And we've talked about when mom should get Rhogam. Remember, Rhogam is given to all Rh negative mothers at 28 weeks, regardless of what type the baby is. Postnatal Rhogam is given after delivery within 72 hours of delivery if the baby is Rh positive, okay? That's 1 standard dose. Before administration of that Rhogam postnatally, blood bank will always do the fetal screen. Remember, during birth, the fetal maternal exchange occurs, and we want to make sure that only the routine 30 ml total bleed occurred. In the event of a traumatic delivery, something goes wrong, and there is a higher bleed, then we would have to do a Kleihauer-Betke to determine how many vials of Rhogam to clear the entire bleed. And remember, when calculating that Rhogam, do not forget to add an extra vial to allow for any type of calculation error, and to make sure that all of those fetal cells are cleared so mom does not build anti-D. Okay, and remember, this is only in Rh negative moms, okay? This is not a concern for Rh positive because she has the D antigen and she can't build anti-D, all right? So this is only for Rh negative moms. Now you'll have some, and I had this happen, I promise, you'll have some clinicians that want to order a fetal screen on an Rh positive mom. All right, if you do a fetal screen on an Rh positive mom, the fetal screen is to detect any Rh positive cells in an Rh negative patient's circulation. You do a fetal screen on an Rh positive patient, it's going to be positive, I promise. All right, so there is no point, and clinicians will argue with you, I promise, there is no point to do a fetal screen on an Rh positive patient. It's going to be positive, okay? Now, if they call you and say, well, I think there's been a bleed, I want to detect how many fetal cells are in her circulation. I mean, if she's Rh positive, does it matter? Then they need to skip the fetal screen and just order a Kleihauer-Betke. That would be a more quantitative test for them. And then we went through some case scenarios, both in lecture 27 and in 28, over interpretation, mom and baby. And you guys will have more practice with this in the corresponding labs as well. So you'll have some more scenarios to go over too. So make sure you feel comfortable approaching those moms and babies. Board of Certification loves to ask questions on those. All right, so identifying hemolytic disease of the newborn and what type, what is causing it, and does mom need Rhogam? Remember, if mom has already built anti-D, so she has active anti-D, she does not need Rhogam. All right. All right, does anybody have any questions? All right, so I will stop there for today, and we will resume with lecture 29 tomorrow. All right, so you guys stay safe, avoid the COVID-19, and stay up on your email. All right, so any announcements from UAMS, and I will see you guys later. Email me if you guys are studying and have any questions. All right, bye, you guys.